go ahead and take a moment to, again, drop in to the chat where you are geographically based and what organization you're representing today. Welcome to our folks on the West Coast. It's great to see you all, King County Housing Authority. Representation from the Midwest. Welcome, Peggy from the Michigan State Housing Development Authority. Hi to our colleague down the street in Baltimore City, Dan Pontius. Hello to our folks down south out of Dallas. Wonderful. Please feel free to continue to drop that information into the chat so everyone has a sense of where folks are tuning in from. I'm Adria Crutchfield, the Executive Director of the Baltimore Regional Housing Partnership. BRHP is a Baltimore-based nonprofit with the mission of expanding housing choices for families with low incomes who have historically been excluded from housing opportunities in well-resourced neighborhoods. As the Regional Administrator of the Baltimore Housing Mobility Program, BRHP couples housing choice vouchers with housing counseling services to support 4,300 families, primarily with children, in accessing and transitioning successfully to safe, healthy, and economically vibrant communities throughout the Baltimore region. If you aren't familiar with the Housing Choice Voucher Program, it's a federally funded program that serves about 2.2 million households nationwide and makes housing in the private market more affordable to eligible families with low incomes, people with disabilities, and older adults by providing rental assistance that makes up the difference between the market rate rent and 30% of the renter's adjusted gross monthly income. Here at BRHP, we strongly believe that housing and health go hand in hand, and that's why we're very excited to host this discussion this afternoon. We hope that you not only gain insight on the outcomes of this specific study, which was recently featured in the Journal of the American Medical Association, which my colleagues will drop a link to in the chat shortly, but also an understanding of how housing mobility programs can improve the well-being of an entire family. One of the questions we hope today's discussion will answer is what impacts do a stable home and quality neighborhood have on the overall health of youth and adults? We also hope to shed light on why Congress should significantly increase the funding and flexibility needed for the housing mobility programs across the country and for organizations such as BRHP. And now I'd like to introduce my distinguished panel. This study was led by Dr. Craig Pollack. Dr. Pollack is the Katie Ayers Endowed Professor in the Department of Health Policy and Management in the Johns Hopkins Bloomberg School of Public Health and the School of Nursing. He's a practicing internal medicine physician whose research focuses on the intersection of housing and health. We are also joined by Dr. Torie Grant. Dr. Grant is a graduate of the University of Maryland School of Medicine and the Johns Hopkins Allergy and Immunology Fellowship. Dr. Grant is an allergist immunologist at Johns Hopkins University School of Medicine. Her research interest is indoor exposures and long-term lung health. And last, but certainly not least, we also have co-author of the study and my colleague, Pete Cimbolic. Pete is the Managing Director of Operations and Program Evaluation here at BRHP. He is responsible for evaluating and enhancing our core programs and leads many of our special initiatives. Previously, Pete worked at the ACLU of Maryland, assisting with the Thompson versus HUD lawsuit and supporting other fair housing work. So welcome and thank you all for spending a part of your day with us. So to get things started, I'm going to ask folks on the panel to let us know one by one. We'll start with you, Craig, what your role was in the study.
Sure, I've been with the study for quite a long time since its beginnings, working to try to come together with a team of wonderful researchers, including Torie and Pete, to try to spearhead this research and get funding to recruit the group of individuals who we followed and learned from, and kind of analyzing and writing up the results and working out to share the results. So it's kind of from beginning to, I'm going to say not end, but middle right now, to try to keep understanding and learning from the families that BRHP serves.
And Torie, share your role.
Hi, and thank you for having me. I am kind of one of the pediatricians on staff, one of the co-investigators through the Department of Pediatrics. And I have been with the study team, I believe, since 2018 in helping with the study design and kind of day-to-day study team functions, and have wonderful mentors and collaborators in Craig, as well as the other pediatricians, Dr. Elizabeth Matsui, who's based out of Texas, and Dr. Corinne Keat, who is in North Carolina, who both were previously at Hopkins, but now are still heavily involved in the study.
Pete.
So Pete Cimbolic, and I think I am part of the broader team here at BRHP who has been involved with this study since its inception. And that includes board members, current and former staff, and really our role was to help provide guidance to the research team in terms of just programmatic concerns that impact the study and the evaluation, and help in recruitment for the study, and as well as just providing support throughout the life of the study period with the research team. To ensure that they're getting access to the clients who are enrolled, and also, flagging for them any programmatic changes that might have impacted, the results or the volume of people moving through the pipeline.
Thank you all for sharing your specific roles. So let's dive into the conversation. We'll chat for about 25 minutes, and then we'll open it up to the audience for their questions. So please be thinking about your questions and be prepared to ask them. I'm going to direct this first question to you, Craig. Please share a little about what started this research, what prompted you to investigate the connection between housing choice vouchers and family health.
Great. So when I went to medical school, there was not a lot of discussion on kind of social factors and social determinants of health. And over the last while, I'm not going to say the number of years, there's just been a real increase in interest in kind of how these social factors, how where we live, work, and play influences health. And so that kind of growing interest and understanding in social factors is what led me to kind of, as I started out in Baltimore and in Hopkins, to learn a little bit about the housing mobility program. And I think initially I came to the program with this sense of like, what an amazing opportunity to help build our knowledge on the ways that our neighborhood environments impact our health. And there's this like methodological challenge in doing neighborhood research, in that the way that people choose their neighborhoods is not at all random, right? Like there's a lot of things that lead me to choose a neighborhood that I choose to live in right now. And that's true for everybody. And so kind of methodologically, it can be really tricky to try to disentangle these different threads of, is it because really neighborhoods matter, or is it because people who move to this neighborhood are fundamentally different? And so I think initially, and kind of, to my own detriment, I think I came to this from a methodological perspective. But I think in talking with people, like I saw Barbara Samuels on on this call, and talking with others and learning more about the program, I really learned the tremendous value that the program does. And it became much more this, like, not just a epi method study, but this real kind of deep interest in the kind of the policy lever that you're working with, and what BRHP is trying to undo in this systemic racism of housing markets, and how people get treated. So I think that was what started the initial study and my interest, which came from methodological and really grew from there. I would also say that kind of the reason to focus on asthma for this study was really one based on kind of discussions with with folks at BRHP and with board members, and then learning from the clients about kind of what are some of the issues that they think are changing in their lives. What are some of the health concerns that they're seeing that are getting better with their mood? And so I am not a pediatrician, I'm not a specialist in asthma, but when kind of hearing that these are some of the issues that seem the most salient, that seem the most pressing, and seem to really change as people move, that's when we brought together this team and started partnering with others, including Elizabeth Matsui and Corinne Keat and Torie and others, to try to understand kind of what is it about moving that impacts asthma? What can we learn, and what can we try to extend our knowledge around this?
Well, we certainly value your interest in our approach and your partnership over many, many years. Pete, can you talk more about BRHP's involvement? Was there something specific that prompted BRHP to be interested in participating in a study like this? How did it all get started?
Sure, yeah, and I think Craig touched on a little bit. Barbara Samuels was really instrumental in learning about the experiences of the families who were moving through the Baltimore Housing Mobility Program in the early years of the program, and even prior to the settlement agreement in 2012. And she did that with the ACLU of Maryland in conducting annual surveys of households who moved with the program. And those surveys revealed significant changes in terms of health improvements for both children as well as the caregivers. Overwhelmingly, folks were reporting that they were experiencing far less stress in their new home and neighborhood. And so I think after years of hearing that, Barbara, around the time of the settlement, I think, launched a survey focused more on the health outcomes for the families who are moving with the program. And that really laid, I think, the foundation for this, in that the largest single sort of change that folks reported was around their asthma outcomes, and lower symptoms and lower exacerbations. And so I think that, with that information, data, as well as, I should mention, there was extensive interviews that we did at the ACLU of Maryland with folks who moved, just to learn more about that experience. And I think once Barbara and Craig sort of connected on that, it really laid a foundation for this research.
And just
as we're talking about that connection, I do want to just also, I would be remiss not to give a shout out to Stephanie DeLuca, who's a sociologist at Hopkins, who kind of helped introduce me to Barbara and BRHP, and has been just such a huge supporter of the research around these programs and trying to build a really strong evidence base to understand families' lives.
And I'll just add that Barbara Samuels, who we've mentioned several times now, is one of our founding board members, and she has joined us today in the audience. So Pete, could you maybe give us a sense of any potential concerns that BRHP had at the onset of the study, especially when it comes to sharing client information?
Sure, yeah. I mean, I think any organization working in direct services is maybe a little skeptical of participating in research. And I think, historically, it's common for low-income populations, in particular Black households with low incomes who are studied, to be put under the microscope, but there's little gain for them. And, sure, academic papers may have been penned, but little was done to sort of improve their conditions or take that information and improve their lot. But the MAP team really went to great lengths to ensure that they were designing in such a way that they were providing information to clients, that the results of this could really prove to be a big boon, or a big plus for housing mobility generally, so that more households could be could have the opportunity to participate in a program like this, and of course compensate the clients for their time, or the in the study and participation in the study. I think the other thing that was at the preliminary discussions around the study, there would have been concern if this was a randomized control trial, just because the staff and the board all know that what we do works in terms of improving the neighborhood conditions, really, and all of the impacts that can have, and from what we heard anecdotally as well as from surveys. And so we didn't really have interest in participating in a randomized control trial, because we didn't want to not offer people these services, these essential services. And so the MAP team found a way around that. There's the Eureka cohort, and Craig, you might need to help me out on that acronym. That is sort of the control group for the purposes of this study. And that really allowed us then to, they were just enrolling families directly from our program. And it was an opt-in study. And so I think with all of those factors, the concerns were really laid to rest from both the staff level as well as the board of directors level.
So before I let Craig get into more of the nitty gritty related to how the study was set up and the process, I do just want to mention that I appreciate you, Pete, mentioning that this was a big benefit to the housing mobility program kind of nationally in terms of, again, demonstrating the effectiveness and the positive outcomes for the families we serve. And I see quite a number of folks from other PHAs who have joined us today, and that's wonderful to see, and hope that you all will consider incorporating something like this on the front end of your housing mobility programs to the extent that you're just now launching this. So Craig, turning back to you, and then we'll get Torie into the mix, but could you share a little bit more about the length of the study, the process, the data collection, and the review?
Yeah, absolutely. And to build on what Pete was saying, that I think research often moves at the speed of trust. And so that I think that the kind of establishing the relationship and learning how BRHP works and BRHP learning how our research team works really took time. And I think that was time that was really important to take and to build and grow. And so the way that this worked is we recruited a sample of families whose kids had asthma. And to do that, we went to the different intake meetings that BRHP was holding and told people about the study and said, hey, if you think you might have a kid who could qualify, come talk to our team. And so our team would wait at the end of the meetings, and some families would come up and we'd do a screening. And for families that qualified, that had a kid that was had asthma that was severe enough that we thought we might see some changes over time, either getting better or worse, we recruited them into the study. And what that entailed was that we would go and do an initial home visit with them, where we would ask the parent and the kid different questions. We'd do some breathing tests with the kids. We'd test them to see if what they were allergic to. We'd vacuum samples of dust in their house. We'd do air monitoring in their house. Kind of all of these different techniques and tools to really understand kind of at baseline what was going on in their environment. And then 3 months later, we called them to see what was happening with their asthma. 6 months after their initial enrollment, we went back to their house. So every 3 months, we were having contact with them that varied between a telephone call or a detailed home visit. And then we followed individuals for up to a year after they moved to try to get at that initial period of kind of before they moved and be able to compare it to after they moved. We recruited families from about 2016 onward. We ended the study period at 2020 because of COVID and everything that happened with that, and kind of the difficulty of understanding breathing patterns and asthma during that time period. So kind of data analysis ended in 2020. We've now started with additional funding from the National Institutes of Health. We've started re-recruiting families into our study, and to try to understand what happens to their long-term breathing and asthma changes based on the results that we're going to talk about in a few minutes.
So yes, speaking of those results, Torie, one of the findings that the post-move data demonstrated was a reduction in asthma symptoms by up to 50%. Could you talk about what that means, specifically about what we know about lung function, and why that sample was important?
Great, thank you so much. So in pediatrics, well, kind of taking a step back, we're so interested in asthma in urban centers because children who live in urban centers are at greater risk for developing asthma, as well as are known to suffer greater asthma morbidity, meaning that they have more symptoms, more exacerbations, worse asthma control, and so they're at risk for all of those bad asthma outcomes. And when we look at asthma symptoms, that's one of the main outcomes we always focus on in pediatric asthma research, because symptoms are so disruptive to the life of a family. They cause children to miss school, they cause parents to miss work, they result in missed sleep. And so when children are having asthma symptoms, it not only stresses the family, but it it impacts them negatively from an educational standpoint, from a financial standpoint, which overall impacts the whole family, and not only their quality of health, but their quality of life. And so the main way we typically control asthma symptoms is through inhalers, inhaled steroids, as well as other oral asthma medications. And a reduction of 50% in asthma symptoms is huge. That takes us from having symptoms 4 days a week to 2 days a week, or waking up at night 4 times a month to only waking up at night 2 times a month. And so this is going to have a very large impact on the children's day-to-day health, as well as the overall health and function of the family. And so having that big reduction was surprising in that we didn't do anything to their asthma, but also wonderful in seeing that their asthma control greatly improved and that their asthma symptoms really decreased, which was wonderful. We care about it from a lung function standpoint, because again, when we're talking about pediatric health, children's lungs grow fastest kind of during their preteen, tween years. And so lung function plateaus really, when we're talking about lung function, we're talking about how much air you blow out, how much air you can both inhale and exhale, and how quickly you can blow that out and how forcefully you can blow that out. And there's all different types of research that has linked that to not only just lung health outcomes, but overall health outcomes. And so we're particularly focused on children because that's when they have the greatest increase in growth of their lung health or their lung function. And again, it's kind of from those tween to early teenage years. And so if we could make a difference during that time, we could potentially affect their long-term lung health, which is obviously the goal when we're thinking about a study in terms of pediatrics, that we want to affect their, not only their pediatric health, but their adult health as well. And so one of the biggest risk factors for having lower lung function or lower lung health is having repeated symptoms and repeated exacerbations. So if you can reduce their symptoms and their exacerbations, you have the potential to affect their long-term lung growth and their long-term lung health.
Were there other surprising findings, both Craig and Torie, that you saw? And maybe you could talk a little bit about stress reduction.
Yeah, so maybe I'll just to underscore something that Torie said, and Torie, tell me if I've gotten this wrong, but the idea that your lungs kind of continue to grow and then kind of as we get older declines over time is sad and depressing to me, and also the idea that there really haven't been like medicines or other kind of treatments that kind of change that lung function trajectory. So like if moving is something that does that, like that's huge. That is a really, really big, important finding. And it's something that we're following up with this kind of long-term study. Because again, that to me, when I kind of learned about that, and it's not something I knew about before, is I think incredibly important. And Torie, do I have that right? Did I get a turn?
You have that absolutely correct. So lung health and lung growth kind of plateaus around age 25. So most of us on this call are unfortunately on the downslope of that lung health and lung growth. And your lung health in adulthood, again, is affected by how rapidly and how much your lungs can grow during childhood. And having lower lung health in adulthood, lower lung function in adulthood is linked to having lower lung health and lower lung function in childhood has been linked to having lower lung function and lower lung health in adulthood, and puts you at increased risk for obstructive lung disease like COPD, chronic obstructive pulmonary disease, emphysema, bronchitis, and severe asthma. And so it's really a critical window in childhood that if you're able to change their lung health and lung growth, that you could change the trajectory of their growth for their lifetime.
So Adrian, coming back to your next question about some of the other findings and what was surprising. So, we were, I think we weren't surprised based on kind of everything that we'd heard about BRHP and the stories that we'd learned to see that there was a reduction in asthma symptoms and exacerbations. The project we did went a step further. And the reason we went into people's houses and the reason we kind of collected all those samples was to try to understand what was going on that was mediating, that was kind of on the pathway for this change. And for that, I kind of went into it thinking that it was going to be mouse and cockroach allergens, which we know are some of the big drivers of asthma exacerbations in Baltimore. And we also know that a lot of the kind of home remediation that's been done for mouse and cockroach allergens, that sometimes it can work well, but sometimes it can be really difficult to eradicate these exposures for kids. And that even some of the best kind of most comprehensive plans can still, that go into the home and try to remediate, can still have difficulty. So we thought that kind of the report would really focus on those factors and how those changed over time. And we did see a change in those factors, but I think to our surprise, we didn't see that those factors were what the critical element was in the change in asthma, asthma exacerbations and asthma symptoms. I think there are a couple different reasons for that, and it doesn't mean that those factors are not important for a lot of kids. I want to be really clear about that these factors still matter. These types of allergens can still be really, really important for a lot of kids, especially kids that are sensitized to them, which not everyone in our sample was. We didn't recruit kids that were only allergic to mouse or only allergic to cockroach allergens, different study. But instead, I think that it's fair to say that, stress was the big exposure that we saw that changed and that was really responsible for, we think was responsible for a lot of the changes in asthma exacerbations. And so people feeling safer in their neighborhoods when they're walking during the day and when they're at night. People reporting less urban stress seem to be really big factors that explained about a third of the decline in asthma exacerbations. And so that is really big when you think about kind of like, how are we addressing asthma, right? Like it's these kind of changes in this level of urban stress that seems to be really, really important.
And can I just ask you to maybe put a finer point on that? And please correct me if I'm mistaken here, but the stress reduction you found in both children and heads of households, or heads of household that was impacting children?
So yeah, we measured a lot of these changes because the kids were kind of a pretty broad range for this. A lot of these were measured at the adult level. So we asked kind of parents like, how are you feeling about safety in your neighborhood? And so we kind of followed that over time. And those reports, those parental or caregiver reports of the stress and safety were what we found mediated the changes in childhood asthma.
Incredible. Thank you for clarifying that. Pete, as you and I both know, this research adds to an existing body of research on housing mobility and the impact of the Housing Choice Voucher Program, coupled with counseling supports. Could you explain maybe how these results further that body of research?
Yeah, I mean, I think so. It's an ever-growing base of research, and I think for housing mobility is still relatively young compared to many of the other housing assistance programs that our country has had, and for decades there really was not a strong evidence base. And in the 90s, of course, there was the Moving to Opportunity study, and in terms of the short-term outcomes or results from that study, I think it was lackluster from the standpoint of the advocates for housing mobility. But then with the Raj Chetty research, the Harvard economist, as well as Craig's research on the MTO households, it really showed that there were changes long-term that those households experienced, and that specifically the children in those households experienced, which really helps to make the case for housing mobility services and dollars going to that. I think that research was looking at the MTO, and now we have an example where we're looking at sort of a contemporaneous, this is an active program that is, we're still leasing households, we're still providing these services, and these are very recent results in terms of what this data shows. And so that really just bolsters the case to policymakers, to Congress, that additional funds should be allocated for housing mobility services. And that has come to pass. I mean, so there was, of course, there's the Housing Mobility Demonstration Program that Congress funded several years ago, as well as for the first time, mobility service dollars that are made available through HUD, through a NOFO that recently was published. So that's exciting. I think there's far more to do. There's over 2,000 public housing authorities across the nation, and there are, millions of voucher households who could benefit from these services. So I think this just really helps to make the case in a more real-time and contemporaneous way.
Appreciate that. You threw in a couple acronyms, and I just want you to spell those out for folks in the audience who might not know them. So MTO.
Moving to Opportunity.
That was, go ahead.
That was a study done in the 90s by HUD across, I believe, 6 sites. And it was a randomized controlled trial where some households receive voucher assistance only, where some households receive voucher assistance plus some services. And it looked at what those outcomes were for those households in the short term, just in terms of the neighborhood context, the change in poverty, things like that. But then in the long term, some of these other factors related to employment, college attendance, health, and so the opening up that vault of data by future researchers has really yielded a lot in terms of the long-term outcomes that are seen from that.
Thank you. Pete also mentioned the mobility services funding that's available through HUD through a NOFO, which is a Notice of Funding Opportunity, I believe. So that's that acronym if you weren't familiar with that term. Pete, could you maybe just share how BRHP has incorporated some of these learnings into our core mobility program? And then those in the audience, we're about to turn to you. So please get your questions ready.
Yeah, I mean, in terms of how we're incorporating some of these findings or what we've learned from even just participating in this study, one, I think, and one of the most exciting things is that, we're partnering with the Housing Authority of Baltimore City, as well as other health partners on the Healthy Children Demonstration Program. And it really is an outgrowth from all of what we've learned from this program, and from what we've heard from our clients, that the health impact of a move can be significant. And so with that program, there are health partners who we've worked to attract and to establish relationships with, who are making referrals of households who have voucher assistance through the Housing Authority of Baltimore City, and who have a child in the home who could benefit from receipt of these services because they have a health condition that's caused by or exacerbated by conditions in the home or neighborhood. And so that program launched in the spring, and we're enrolling folks. We're having referrals from those health agencies to us and the Housing Authority to receive these services. And we're really excited about that because that's partnership. There's often these silos between health and housing. And I think this is really a way for us to cross-cut across those silos. We're learning a lot on the health side. A lot of the folks who we're working, a lot of the health partners we're working with, we're also trying to, really steep them in the language of housing and further understanding that. And then I would also just mention that a lot of, what we've learned from those partners, as well as the research team, is being folded in, and we're thinking of new ways of folding it into our curriculum and the services that we provide, as well as the referral partners who we can refer households to. Because with our counseling team, who is working with families both pre and post move, they're a trusted partner to the tenants who we serve. And so they're sharing a lot of information and looking for referrals and looking for connections, particularly in those new neighborhoods. And so if we can help facilitate that on the healthcare partner side, then it only improves their resources that they have available there in that new neighborhood.
Absolutely. And if I could just add one more thing, again, to you PHAs who might be in the midst of launching mobility programs, think about collecting as in your initial assessments with families, information related to their health, their children's health, those types of things I think could be critically informative. We have a question here in the chat that I'm going to read, and if you have a question and you'd like to ask it yourself, feel free to raise your hand and we'll call on you. But from Terry Stoudemire, she's with the ABLE Foundation. Have you or do you plan to share the results of the study with Medicaid, MCOs, or other insurers? And any chance of getting Medicaid funding for housing mobility?
If I can start by weighing in and say that we are trying to share this as broadly and widely as possible. And so if people, know people that we think we should share it with, please let us know. We are certainly trying to reach out to people in healthcare organizations and insurers to think about kind of how does this get integrated. And I would say that the ways that healthcare screens for social needs and refers patients and then potentially helps pay for these social needs and the social services is an area where there's a lot of active research. There's been some really interesting studies that have just come out on accountable health communities, which was a Centers for Medicare and Medicaid Services kind of pilot study, showing that maybe there's some benefit, but maybe it doesn't work in the way that people think or could work. And so I think this is area of a lot of active interest, and I think that we're working to try to push this. I would also say that there is, I think, kind of pathways for these types of services to be paid for by Medicaid under 1115 waivers, which are where kind of the CMS, the Centers for Medicare and Medicaid Services, grants a waiver that states apply for to test different service delivery, so long as it doesn't increase costs or decrease quality of care. And that housing services, like some of the mobility services, in my read, and I'm not a lawyer, so please, don't quote me on this, but it seems like it could potentially fit under some of these provisions. So, I think there's potential to work with states around Medicaid waivers to think about testing different models like this that could be beneficial and incorporated into this broader application.
Peter, Torie, anything to add?
I would just add that, and thanks for that, Craig. I do think that the thing that I think many people think about when they hear mobility programs is, it's a very expensive venture, and it takes a lot, and sure, there's a lot of infrastructure that's required, but the cost of the services that we provide is really the equivalent of 2 to 3 months worth of rent for those typical households. And so when you look at that in terms of the larger picture of the typical time that a household with the housing choice voucher is served, that's a really small portion. And if you think about these downstream benefits that really, save the government in a lot of cases, funds in other programs, sure. There is a strong case to be made that small upfront investment can really yield a lot of downstream savings.
Absolutely. And I would just add that one of the future aims and goals of the study with our current follow-up population is to link to Medicaid data and do a cost effectiveness analysis, which would be, even more persuasive to payers. And so stay tuned for that data.
Great to hear. Craig has dropped that CMS guidance that he, I think, referenced in his response into the chat. So feel free to click on that. Other questions? Is there anyone that has a question they'd like to ask? Feel free to raise your hand, unmute you.
I'll put in the chat. I recognize that the recent JAMA article is behind a firewall, and if people are having trouble accessing it, please feel free to reach out to Torie or myself, and we're glad to work to get you a copy of the article or the accompanying editorial as well.
Thank you, Craig. While we're waiting on a couple more questions, just another question for the panelists. What are you hoping will change in the housing and health fields as a result of the study? Maybe some short-term changes that we might see versus maybe some longer ones?
In terms of kind of longer term goals, I think a lot of us in the pediatric world, and definitely Craig and the health policy world, have been saying for a long time that housing is health. And this absolutely underscores that belief. And, that is a long-term goal, that we see quality housing as healthcare.
I agree with that. I would say that, the programs that Pete mentioned about the Healthy Children's Voucher, where recruiting children who might benefit from healthcare providers, and healthcare providers kind of broadly considered, that includes things like, public health authorities that are going into families' homes and trying to work with kids with asthma, working with expectant moms to address the health needs. Like this kind of collaboration between healthcare providers and health providers and folks like BRHP that work on housing is new and so important, right? Like it is just critical to try to address these drivers of health, to move upstream from where we are and try to kind of think about health broadly. And it's, I think we're still relatively early in this process, right? Like we're not there in terms of how we think about, screening and referrals for housing, for food, for so many of the other factors. And so, I think that the thing I'm most excited about is learning from the Healthy Children's Voucher about how we do this well and how we keep improving it and how we keep on thinking about integration so that, that we see these as two sides of the same coin.
I'd also just mention that we're already seeing some of this, and it's really exciting to see with the Healthy Children Voucher demonstration, in that some of the health partners who we're working with, we obviously have a shared goal of sort of improving the health condition of the household, and they're recognizing the importance of housing as a key component of that, and even sort of supplementing some of the work we do in terms of providing housing search assistance, for instance. We had a recent case where somebody one of the community health workers actually shared a list of units that she had found, and which was great for us, and we helped to then sort of facilitate those connections further. And so I think that increased integration between the two systems, the health system and the housing system, is a really, it's great to see, and it could yield lots of good results for the households who we're all serving and the overlap that we serve.
Can I just say one of the things I love?
Perhaps maybe a little more specific. Oh, go ahead, Craig.
Oh, so I just say one of the things I love here is that I think that kind of when these conversations, 10, 15 years ago, it was that this was a different lane than healthcare, right? Like that this was not something that healthcare really would or should do. And I think the conversation is now kind of like, how do we do it? How do we fit it into workflow? Are there ways to make it feasible? And, I think there's also a change on the housing side of the equation, where, that health is kind of considered as part of what they're helping to provide. Maybe I've got that wrong, Pete. You're shaking your head yes, which makes me think maybe it's the right direction.
Yeah, and I'd also just add to just that, and you mentioned screening and some of the screening that some of these healthcare providers provide or do with when they're first working with a client. I think that has yielded with increased focus on the social determinants of health. We're hearing from some of these partners that they don't know where to turn when it comes to making housing referrals. And so one, even just providing, greater education in that space, but also having them partner with the advocacy that's required to get more resources for assisted housing. Because we all know, like, there are not many good places to turn right now. There are a lot of wait lists that are closed. There's not a ton of new construction of affordable housing. And so there's, 1 in 5 households, 1 in 4 households who are eligible for voucher assistance actually receive it. And so with healthcare partners helping to advocate for increased funding for housing assistance, that also could really yield some good results.
Thank you for those goals and those hopes. We have another question here in the chat, and actually, since Dan Pontius happens to be a colleague of mine, Dan, do you want to unmute yourself and ask the question to the group for yourself, or we can unmute you?
Sure.
Great.
Let's see if I can get time. There we go. I'm just kind of curious. I mean, this idea about stress is just really fascinating to me, and I'm just curious if there's a way to explain it to a non-scientist like me, like how you came up with the idea that it's about a third of the impact.
Corey, do you want to take the math? So this, we work with the statistician and other members of the team to think about something called mediation models, which are models that try to tell you kind of like how much of the effect of the exposure moving on the outcome here, asthma exacerbations kind of work through this pathway of stress versus how much are kind of not through that pathway. And there are different mathematical models, which I'm also a layperson in this sense of that I'm not going to begin to try to kind of derive for you. Torie, do you have a different explanation that?
No, yes. This is when we would phone our good friend Roger, who is on the paper as well. And yes, that exactly what Craig said, that it tries to explain the effect of moving on asthma symptoms. And I'll just add that biologically, it does make sense that stress could affect asthma symptoms and asthma control. There's evidence mostly from like prenatal literature that maternal and prenatal stress is actually associated with increased allergic markers in offspring. And there's some evidence as well that children who report chronic stress have a decreased response to asthma medications. And so taking a step back and thinking about it from an asthma standpoint, it is biologically plausible that reducing stress actually does affect allergic asthma.
Yeah, just working with Pete and Adria on housing mobility, I feel like a little more of an understanding of how that plays out. Like, because I've also worked in housing where we've worked to reduce allergens to try to reduce asthma too. So it would just be really interesting to understand a little bit more like how those two kind of interact. Just in terms of even, working with agencies and just being able to articulate the potential impact of moves like this to a broad range of constituencies. But thanks, this is fascinating.
And I want to be clear. I think we're not saying that these types of like home remediations don't matter, right? Like, I think that would be a wrong takeaway from this message, given from the study, given the kind of the way we designed the study. And I also think you could imagine where there's an interaction amongst stress and allergen levels, where that living in a really stressful environment can exacerbate the effects of high allergen concentrations on stress. So I think, Torie, do you want to?
Yeah, I'll add to that. So we didn't recruit participants, like Craig said, we didn't recruit participants. He used the word sensitized. So what that means is that they have evidence of an allergy antibody to mouse, cockroach, cat, dog, dust mite. We didn't recruit participants specifically who were allergic to those different indoor exposures. And again, repeatedly, the ones that matter most in urban centers are mouse and cockroach. And also from the urban exposure literature, there's kind of, we don't like to use the word cutoff or threshold, but children who are allergic and exposed to higher levels of mouse and cockroach, there tends to be a dose response in the driver of their asthma. And so it's possible that if we had recruited a different population that was both allergic to and then exposed to high levels of mouse and cockroach allergen and moved them to other areas that had less mouse and cockroach allergen exposure, that the results from the allergen standpoint may have been different.
Great, thanks.
I'm not seeing any other questions and no raised hands, so I'm just going to pitch one final one to the panel. But just in terms of those who have joined us today, whether they be housing practitioners themselves, staff at these organizations, policymakers from the philanthropic community, any kinds of call to action, any ways that we can be supportive for some of these goals long term, and some of the hopes that we have between bridging health and housing.
I'm happy to start. I mean, I think one, I do think that for funders, as well as even potential housing mobility practitioners, I think it's really essential that this work is done, and that more programs need to get off the ground, and we're seeing sort of momentum in that. On the funder side, a lot of folks are looking for funding to do this beyond what the federal government can provide at the moment. And so it's really important that the philanthropy community helps to fund some of this work. helps to establish that, further establish that evidence base, so that, you know, the federal government does provide further investment down the road for these efforts.
And if I may add to Pete, this is Bill Tamburino. If I may add to Pete's thought, and we need to do these simultaneously. We need to have the conversations with our Congress people on why this is important, how these things are connected, because obviously it would be valuable to have legislation and programs that are designed to address things as we understand, in ways that we understand how they work. So I'm not trying to be critical there of the existing programs, but we can make some improvements, and it's clear, and we need to provide that message to the people in Congress and in state offices.
Thank you, Bill. Couldn't agree more. Bill Tamburino is a BRHP board member and actually is our vice chair and heads our policy committee. So appreciate that. So go ahead, Craig.
I was just going to say that I think we're so grateful for BRHP's partnership on this project, and the fact that you guys are willing to kind of partner on this research is just, I think, just really wonderful and really unique. And so, you know, as other programs are thinking about partnering, that it's just, you know, I just want to encourage it and to try to extend this kind of research and evidence base. And if there's ways that from the research community we can be useful in kind of helping our evidence kind of get out there and reach a broader audience that might be receptive to making changes based on it, that we're absolutely happy to try to be part of that conversation.
Thank you, Craig. And we will be sure to follow up with all of those who registered, whether or not they could attend today with this recording and lots of other resources. So a big thanks to our panelists for such an insightful conversation, and to all of you who spent your lunch hour with us today. We'd love to stay connected with you. Please consider going to our website, brhp.org, and signing up for our newsletter. We are also on social media, Twitter, LinkedIn, Instagram, Facebook. So feel free to follow us there and stay tuned for future BRHP in Conversation. Have a great day.